Good evening, everyone. Myself, Dr. Masimukku Dheeraj, third year postgraduate resident from Sri Lakshmi Narayana Institute of Medical Sciences, Puducherry. My title of the paper is Role of Computed Tomography in Bowel Ischemia. Introduction. Bowel ischemia, which is decreased blood flow to the bowel, is a serious catastrophic condition that requires immediate intervention or surgery in the acute phase. It varies from initial stage of localized transient ischemia to potentially fatal necrosis of gastrointestinal tract, with the chain of events being necrosis of bowel wall, bacteria proliferation in the bowel wall, releasing gas in the wall itself, which is pneumatosis intestinalis, entry of gas through mesenteric vessels into the portal vein, pneumatosis portalis, sepsis, or intestinal perforation or death. MDCT is used as a first-line imaging choice to confirm, locate bowel injury, to determine its severity, and can also demonstrate the length of segment involved and is used in determining the primary cause. Aims and objectives: to evaluate the role of CT in bowel ischemia, to evaluate the cause of bowel ischemia using CT, to identify the cause of ischemia based on the pattern of the bowel. Materials and methods: prospective study of 18 months duration to evaluate the role of CT in bowel ischemia in indoor and outdoor patients of either sex, being referred to the Department of Radiodiagnosis and Department of Surgery in our college. All the study patients will be investigated on a 16-slice MDCT. Non-ionic iodinated contrast like Omnipac, Visipac is administered at the rate of 2 to 2.5 ml per kg body weight at the rate of 4 ml per second. Serious phases like plain, arterial, portal venous phase are obtained. In this case, we can see there is a paper thin and non-enhancing or minimally enhancing bowel loops. In the previous patient with paper thin bowel loops shows a long segment filling defect in superior mesenteric artery in sagittal and coronal views. This is a case of venous thrombosis with thrombosed superior mesenteric vein with a target appearance of the bowel. And this is a case of trauma with patients in a hypotensive state showing the shock bowel syndrome. Here we can see there is thickening and hyperenhancement of bowel loops showing shock bowel. Another cause of shock bowel showing thickening and hyperenhancement of bowel loops. And this is a case of perforation with non-enhancement of ileal loops. Conclusion: the radiologist plays a central role in the initial diagnosis and for further prevention of progression to irreversible intestinal ischemic injury or bowel necrosis. Thus, multi-detector computed tomography scan can demonstrate the ischemic bowel segment, length of the segment involved, and helps in determining the primary cause. At imaging, it is not only important for imaging of the bowel, but evaluation of mesenteric fat, vasculature, and surrounding peritoneal cavity also helps in the diagnosis of bowel ischemia. The various patterns of bowel ischemia as described can aid in the diagnosis of bowel ischemia and thus in the further management. These are my references.